So thank you and welcome everyone to the Ideas UK Knowledge Nugget for today. I think this is our seventh of the year, so I'm delighted that some of you could attend today. I know we're a bit of a different time zone, and that's because we are absolutely delighted to have a speaker with us from Canada this year. So quite a departure from our normal stance perhaps. So we're delighted to have Dr. Karim, and I'm going to pronounce your surname wrong, so I apologize in advance, but Keshavji, I'm going to allow you to introduce yourself, but he's going to be talking to us about, and we've already been having a conversation beforehand about his innovative approach and his early days with computers, but around creating a market for mobile healthcare applications. And whilst I appreciate many of you on the call will not be from the world of healthcare, I think actually learning lessons and taking those kind of nuggets from different worlds and expanding kind of our own worldview is always helpful. So I would like to hand over to Dr. Karim, and thank you very much for giving up your time. I know it's early in the morning in Canada to join us today and share your experiences.
Great. Thank you so much, Zena and Helen, for inviting me. I appreciate that. And, this is a project I've been working on for the last 5 or 6 years, trying to understand, how do we make healthcare applications, which are really needed, more widely available to people. And I think, so this is my idea of how we might do that. And so I appreciate the opportunity to present. And also, it's not a long presentation. And so I've left quite a bit of time for us to discuss. And as you're listening to what I'm saying, I'm hoping that you will think about 3 questions. The first question that I want you to think about is, what struck you as, wow, this is great. This is something that we need to have. The second question is, what are you skeptical about? You heard something, I said something, and you said, I'm not sure I agree with that. And the third thing that I would ask you to look at is, Kareem, if you made this change here, your presentation would be so much better. Okay, so those are the 3 things that I'm going to ask you to play along with as we explore this presentation that I've put together. And so what I'm going to do is I'm going to tell you the problem, and I'll tell you why the current problem is there and why the current approaches to solving the problem actually fails. And then, I'll share with you how I propose to solve this problem, and then we can have a discussion and talk about things. So if you look at the problem, you'll notice that hospitals and emergency departments are overflowing seemingly around the world. So it's not just here in Canada. All OECD countries are facing the same thing. And the question is, why are they overflowing? Well, because patients are sicker than ever. There's some good reasons for that. People are getting older. The medications that we prescribe to them actually work, but they don't cure them. And so they live longer to get more diseases. But the other thing that we can say is that they are also not getting the full suite of evidence-based treatments and preventive advice that already exists, that they need to help them stay out of hospital. And if we ask ourselves, well, why aren't they getting that? Then the answer is primary care is overwhelmed. There's just too little time in the day. So what we know is that the evidence available out there that needs to be delivered to patients, just what we know, not what people are asking for, but what we know, it's estimated that we would need, a family doctor would need 24 hours in a day 24 hours per working day. So they would have to work every hour in order to just deliver the minimum care to their patients. And of course, that's just not possible. This is based on a really interesting article that I read some time back. I did look at the article carefully, and I said, this is a very optimistic estimate. So an optimistic estimate is that it's 24 hours. And so I think, clearly there's just not enough time in the day for a doctor to do the work that they need to do. And I think apps can help. Apps are shown to improve the care of patients with diabetes, Crohn's and colitis, university-induced stress, anxiety and depression, medication adherence for many, many different diseases, heart failure, travel medicine. Okay, so I think, and this is just a short list that I curated over the last couple of days. The reality is that if we applied ourselves, apps could do a lot. And what I found interesting is that, for a lot of preventive activities, much of what needs to be done is really just educating people. So it's not even any super duper functionality that the app needs to have. It just needs to be able to effectively and consistently educate people and help them implement the interventions that will help them improve their lives. So if we're going to be able to apply apps effectively, meaning that we're not wasting people's time, that the people who really need it are getting it, and the people who don't need it are not being bothered, then I think one of the things we need to do is we need to identify populations of patients who are at high risk of getting sick and requiring emergency room and hospital care. And it needs to be in the near future. So it can't be too far in the future, because the reality is that most of our healthcare systems are run by governments who have short tenures. So, unfortunately, healthcare is politicized. It's just the nature of the beast. And so I think we need to be careful about, what the timeline is, because if it's too short, let's say I can predict that you're going to get sick in the next week, it might be too late to do anything about it. And if we do it over a 5-year period, well, politicians have no patience for that, and probably patients have no patience for that either. So, and then one of the things is we need to do is, once we've identified that person, we need to reach out to them and offer them a convenient way to access that information that will help them address their risk. Okay, so hopefully what we're doing is we're not trying to address an illness, but trying to address a risk. So identify those people who are at highest risk, because, in the past, and our current practice, it's a holy grail of medicine to identify diseases early and treat early. And in the age of AI, it's not about identifying the disease early, it's actually identifying the risk before it even materializes. So can I predict that you're going to get this disease before you even get the disease, and then say, here, let's figure out how to prevent that from happening in the first place, instead of saying that, you need, oh, we detected this disease and now you need a treatment, and now you need surgery, or you need some kind of invasive treatment. Okay, so basically, then I asked myself, well, okay, if that's what we want to do, then we need to be able to do 3 things. We need to be able to identify patients at risk at scale. So everybody in the population, not just a few people, which means that we need, and of course, data for all of this does exist. Okay, so we need to work with the family doctors and identify them at the GP level. educate and motivate them. So once we've identified them, we should be able to reach out to them and educate them and motivate them to make a change. And then once they agree, yes, I understand my risk, I understand what it is that is causing my risk, and oh, I also want to do something about it. I think it's a priority, because not everybody thinks their health is a priority, because, frankly, if I'm going to get a disease 5 years from now, is it a priority for me now? Well, yes, it should be, because you can make small changes now that will have a big impact in 5 years, as opposed to making drastic impacts at year 4, because now you're on the brink of falling off the cliff. And then what we need to do is engage them and help them with the implementing the knowledge that can help them change their life. Okay, so you can see that there's, I've got it down to about 3 steps. It's taken a long time to get down to that level. And the question for us is, well, is that possible for us to do that at that scale? And so my answer is yes. Okay, with new artificial intelligence, we can identify high-risk individuals directly in the medical record using advanced algorithms. And then what we need to do is say, well, okay, I've identified, in a population of 50 million, like you have in the UK, or 60 million, we have 2 million who have this disease. And out of those 2 million, 200,000, which is 10%, show up in the emergency department of the hospital and have a certain utilization rate. Okay, so and so there's a certain cost associated with those people showing up in the hospital, and let's say it ends up being $2 billion or 2 billion pounds. They're not equivalent, by the way. We're working on it. We're working on it. It used to be $2. Now it's about $1.50. But so anyway, I mean, I think the idea here is that we have a cost that's already being incurred. Okay, and this cost is unavoidable because we as a society have agreed that, if somebody shows up to the emergency department and requires hospitalization, we won't say, sorry, you were misbehaving, off you go. No, we look after them. And so there's already a cost against which we can say, if I can lower my cost through education and through apps, then there's a business case for investing against that existing revenue stream, this existing cost structure. Okay, so what we then do is we say, can we come up with a incentive structure to incent publishers of medical applications to actually build apps and make them available? Okay, so I'm going to walk you through how we would actually implement this type of a project. So the first thing is that is identifying high-risk individuals. So there are many algorithms now available for identifying high-risk individuals to predict, future disease, future users of the healthcare system. And in fact, if we have a way of delivering effective interventions to people, then it makes sense for us to be able to then commission researchers and clinician scientists to actually develop new algorithms. Because if I have a treatment for something, then it becomes unethical for me to just wait there and do nothing. We should be doing something. Okay, so then we start to say, well, researchers, can you help us identify? We have a treatment, but now we need to be able to identify the population at risk. And then the algorithms can be deployed directly into the electronic medical record using these standard interfaces, which are now being developed and coming online in North America and across the world, called Smart on Fire. Okay, so the idea is that now we don't have to bring that data to a central location and do things like that. We can actually just send the algorithm directly to every GP. They can handle it in their clinic. And now we're preserving the privacy of individuals without and giving them benefits without necessarily exploiting their, creating problems of privacy or problems of breach. Okay, so that's step one. And then what we do is we calculate the value of prevention. So we develop a business case for preventing exacerbations, complications, acute events, and then ask ourselves, how much should we be willing to pay for this prevention? So if we took the example of, this this particular disease costs us $2 billion or 2 billion pounds, sorry, then the question is, how much should we be willing to pay for it? Well, I would argue that we should actually be willing to pay just a bit over 2 billion pounds, because if I can prevent all those people from getting sick, that's very valuable to our society, because those people will end up staying at work or enjoying their life and spending their money in our economy instead of us spending money on them in the hospital. And so, but I mean, theoretically, and obviously, we're not going to be able to save that entire $2 billion. So we can say, well, what if I can save 50% of that or 10% of that or whatever? It's still a certain amount. And then that's the value that we would be willing to pay. Okay. So then what we do is we take that amount and we say, okay, we're going to break it down into three components. So what we say to ourselves is that if an app is going to work, it means that the patient has to download it. They have to have it on their system. They have to enter data into the system, and then they have to act on the advice that is offered by the app. Okay, so we would have to say these are the things that we're looking for in the app, because obviously, let's say a patient gets better, but they didn't use the app, then we can't say to the app vendor, oh, your app helped. Okay, so what we have to be able to do is say, prove that your app helped. And as long as the patient used your app and they got better, then we will attribute the improvement to your app. Okay, and so we don't pay for things that we don't get. Okay, that's the key thing. Yeah, and that's what value-based care means, is that we only pay when we get the value. And so, the question becomes, who pays? And we think, it's the government or, the insurer that pays, because the idea here is that the insurer doesn't want to actually build the app themselves. They should not want to build the app, because that's not their business. They're not in the business of building apps. So what you want to do is you want to say, hey, I'm willing to pay for an app as long as I get value. And then investors will say, oh, okay, there's a return on investment possible here. Let me invest against that return on investment. Okay, so what we're trying to do is attract investment from investors who are always willing to invest as long as there's a revenue stream. And, I see a lot of this governments across the OECD creating grant programs. Well, my personal opinion is that's a waste of money, because you give somebody a grant, but there's no revenue stream against which they can go and implement that. They're not going to actually generate any economic returns on that grant. Okay, so I think we need to think about how we generate economic returns as well. And so I think we do need to think about these kinds of things, and I think that's my thought around how we get investors to invest, because they're the ones who can build the apps and pay for the apps, and the government can then stay out of the venture capital business and be more in the generate the benefits business. So this is a very busy slide, but I'll just kind of, I've got it in little categories here. So I'll show you how it works. So basically the idea is that we have this app value tracking platform, and it starts here where we risk profile patients. Okay, and so there is this data bucket here that has all the data that a patient that's available on a patient. So for across all the patients, most OECD countries have some system like this, built by the government and maintained by a government-run agency. And so the idea is that it would take all of this information, and the risk profiling system would come in and just query this and say, hey, here's a list of 2,000 patients, or 50 million patients. Can you tell me who's at risk of developing X? Okay, and then that list of patients is sent to the physician, and they vet the list and then recommend the app to their patients. Okay, so let's say a family doctor might have, say, 50 patients at risk of a particular disease. They would speak to the patient and say, hey, you know what? I've got an app that I think that would help you manage your risk better. Would you be interested in doing that? Now, that app will have been built by a publisher who has developed the app, tested the app, and put the app into production. And then the app is in the App Store. So the patient now who has been recommended this app by their doctor goes to the App Store and picks it up. Okay, and then they may get some onboarding support, because I think what's going to happen is that the publisher is going to figure out that, if the patient doesn't use my app, I don't get any money. So I've got to train the patient to and give them some advice about how to use the app effectively. So I think that will probably happen. And then the patient then enters information into the app, and it's tracked in the app value platform. Okay, so the app value platform tracks the value that is being generated by this app. And then there's this governance and evaluation little box here that basically the idea is that their job is to make sure that this whole system is running properly, and over time improving the system so that any frictions that arise are sorted out. Okay, I'm happy to take any questions if people have any questions, because I know this is a very complicated slide.
I think you explained it really clearly, actually.
Okay, wonderful. Thank you so much. Okay, great. So basically, the process would be that, we would say, hey, we would be interested in entertaining apps that do X. And then publishers would come to us and say, hey, I have an app that does X, and we just give it a light review. Okay, so we're not interested in spending a lot of time saying accepting or rejecting. We say, can you please provide us your usability reviews and your research studies that prove the efficacy? Which group of people was it tested on? Because that's the only group of people that we will actually approve it for. And then we put it into the marketplace and let the marketplace decide whether it's going to be a good app or not. And as I mentioned, apps are only approved for the demographics on which it has been tested. And then the physicians are given a list of patients, and the patient can download the app, and then patients can switch to another app for the same indication if they don't like the one that they got, or if it doesn't work for them. Okay, so the idea is that we give patients some autonomy, we give apps vendors an opportunity to invest in and get a return on their investment. And now what we've done is we've created a mechanism for evidence to come into the hands of patients.
So I've got a quick question about how the apps get out there, basically, because I guess if I think, because I've got obviously the pharmaceutical background, and we send sales teams out and they talk to doctors about the products or the devices, how are your GPs, your physicians, made aware of the apps and which apps to recommend, which apps perhaps have been government funded, for example?
Right. So they would actually get a list of their patients that would come right into their inbox in their electronic medical record. And it would just say, here are a bunch of patients. Here's a list of patients who are at risk of disease X. We now have these apps on the formulary, which you may recommend. This one is for, people age 45 to 60. This is for 60 to 80-year-olds, and this is for males who live alone.
Nice.
Yeah.
So it's basically marketed directly at them and with the relevant patients who they could support with the apps.
Yes, because if you remember when you were a pharmaceutical sales rep, you had to explain to the doctor who that ideal patient for your drug would be. Well, no, now we do. That's
AI takes that out.
fully automated. It says, okay,
yeah,
here are the people who would benefit from this app. Here's the people who would benefit from this app, etc.
Yeah, great. Thank you.
Yeah. And how would we know that the app helped? Well, I think the key is that we ask that the patient actually use the app, that the patient enters data, and is there some evidence that the patient actually used that information and made the lifestyle change? So we track the lifestyle change. And if you can see that, the inputs were correct, and then we look at, what were the outputs. So just, whether the patient entered the data or not. Did we achieve the outcome that we were looking for? And then, so in this case, what we're really looking for is, can I drive down the AI risk? Okay, so the risk is driven by certain factors. Okay, so your cholesterol is high, or your blood pressure is high, or your, whatever the factor may be. And the advice, if the patient uses the advice, then those markers should come down. Your blood pressure should come down. Your cholesterol should improve. And when that happens, we say, okay, it sounds like at least it's working. Okay, and that's the things that we're looking for. And so why do we think it will work? Well, first, the ability to identify patients at risk already exists. So it's not like I'm inventing some great new functionality here. There are many proven interventions for preventing disease and complications, which we talked about. That's the 24 hours that a doctor would need to be able to actually just deliver all that care. And then delivering those interventions at high fidelity. So I won't go too deeply into this idea of fidelity, but the thing is that if people don't take their medications, their blood pressures are just not going to come down. So the idea is, how do you help people implement that intervention so that they actually receive the benefit, and then track it, so that that's the benefit of mobile apps, is that you can actually track these things. There is a huge health app market that already exists. So it's not like we're going to go out into a desert of apps hoping to find people that can supply it. No, there's a rich array of apps. And what this will do is it will focus those apps on proven and provable benefits. And I think the missing ingredient from all of this is just our platform that we're proposing. And I think the other piece that I think is very important for apps to work is what we call a enabling clinical environment, which is that doctors and their staff should be encouraging patients to use these technologies. And so, but that's already happening. Okay, so many doctors actually do recommend apps, but it's somewhat ad hoc, and it's based on things that they've picked up here and there. we don't have a pharmaceutical sales rep right now who can go in and say, here's the evidence, here's what you should be prescribing. But I think, the environment, the enabling environment at the clinical level is there. And so, it won't be like, oh, we've got this ecosystem, but now the environment doesn't allow for its rollout. And so just to kind of summarize some of the features of the platform, it leverages advances in artificial intelligence to identify patients at risk. It leverages expertise in the community. So, researchers are doing all of these kinds of things, but there's no way for them to bring these things to market. So if we make it so that investors are willing to invest, then researchers will get the money to be able to bring these to market, or be able to then license it to an app publisher so that it gets brought to the marketplace. The benefit of the system is also that it monitors the usage, benefits, outcomes, and the cost aversion. Did we actually save money? Is all part of the platform. And then, of course, there's this new standard called HL7 Fire, which I won't get into, but it's a newer standard for sharing healthcare data. Just like we had, the World Wide Web allowed us to share hypertext markup documents, this new standard is allowing us to share healthcare data, and it's starting to be plug and play. So I think for physicians, it's not like, oh, I have to install this whole new software and make a huge number of changes. It should be plug and play within their medical record systems. So in terms of the benefits, it can be easily scaled up. It will encourage investment. It will create new jobs in our healthcare sector, because there'll be all these new programmers and new behavior change specialists, support specialists. It will grow the mobile health marketplace. It will make Ontario, and also any jurisdiction that implements this, a leader in health app development, because it's still very early days. The Germans and I think the Danes and the French have moved ahead on this area, but very nascent and very tentative moves in this direction. It will benefit millions of patients. Okay, so this is scalable to millions. It will decrease the physician effort of educating and monitoring millions of patients, which is one of the things that is preventing them from doing this. It's the amount of time. And it will also increase the sustainability of our healthcare systems. So yeah, I'm open to questions and discussion.
I have a question.
Mm-hmm.
So thank you, Kareem. This was really super, super interesting. And for me, it just speaks volumes about, AI being used in the correct way. This is where it really brings value. So that's really a good thing to see. My question relates to risk and how we categorize patients at risk. Both in terms of the system, at what point do we consider patients to be risky? And there may be standards that probably are around that. But also, how do we present that risk profile to the patient so that, they don't interpret high cholesterol as them having necessarily, they're not going to have a heart attack tomorrow? How is that all managed?
Yeah, so I think this is a really good question. So I think the first thing is identifying people at risk. I think, the algorithms are just getting so much better, so much better. We just got a paper accepted for publication, which shows that our new artificial intelligence algorithm can identify people at risk at a 91% rate of accuracy, which is just huge. And
Wow.
And another paper that I haven't even I just got the results of the study, is showing a 93% efficacy accuracy of finding patients. So I think finding these patients, it's going to take a little bit of time for us to get acceptance of these, but I have presented it to clinician audiences, and asking them what they're skeptical about, and they're not. They're like, I just couldn't find, even researchers who, you can count on them finding some flaw in your thinking. They're not thinking it. They're not asking those questions. They're telling me, well, Kareem, the next step is this, this, and this. And I'm like, but I want you to tell me the flaws in my thinking. And they're not, they won't tell you that because they can't find them, or, they're not seeing it. So I think this identifying people at scale is going to be relatively easy. And I think, then how do you communicate this to patients? And, the reality is that there's a huge amount of work that has been done over the last 25, 30 years on behavior change theories. How do you help people move from pre-contemplation to contemplation? And, how do you package that up in a mobile app? So that's a lot of the research we're doing right now, is figuring out how do you take people from, as I say, walking happily down the street, just minding their own business and enjoying their life. And then you tap them on the shoulder and you say, you're at risk of developing a heart attack. Can we have a conversation about that? So I think that's how it starts, I think.
Right.
Chris?
Yeah. Hello, good to meet you. That was fascinating. Thank you.
Thank you.
There's a couple of things rattling around my head. One is about, it's just struck me, I saw a television advert yesterday. It was by Apple. And have you seen the one where they're questioning data security? The setting where someone walks into a doctor's surgery and there's an invisible, if no one else has seen it, it's an invisible voice listing people's conditions. And the lady who's got the Apple app presses the security button and they go, oh, you're not playing, because Apple have kept your data secure. And there's a bit about people like Apple having, well, Apple have got loads of my data already, and they probably know more about me than my own family doctor. And I think that's an interesting one, where the sort of hesitancy and resistance to engage in some of this by some of the wider population, are some of those concerns about data security, because in some ways the Apple people were amplifying those concerns. I just wonder if you have any views on that sort of thing.
I do. I've been studying this space for a good 20 years. So here's what I see. There's a societal view and a legal view. Okay. So in society, it's very interesting that even if you de-identify data, people still think that it belongs to them. Okay. So I remember distinctly this patient, this participant in a research study. He said to me, we were trying to really understand, do they understand what de-identified data means? Well, people get it, okay? People are not stupid. They understand what de-identified data is. So he said to me, well, it's like me, borrowing your car overnight while you're sleeping, driving it around and, just getting my groceries done, and then returning your car to where it was before. What's the problem with that? It's the same thing. For him, it was the same thing. It was de-identified, right? It was anonymous and de-identified usage of my car. And he says, you're de-identifying data and using it, but it's still mine. And so I think, but from a legal perspective, from a regulatory perspective, that's not how we look at it. We say, well, it's de-identified, therefore, there is no sanction to using de-identified data. So I think we do have to square that. But one of the things that I've designed into this is that I'm saying, look, we already share data with our GPs, and we're comfortable with that because the benefits of sharing it vastly outweigh the harms of sharing it. And so the design is that build on that trust that already exists and only have the data in the GP's office. That's why the GP is a big part of this. And then what you do is, if you think about it, do you say to your doctor, I don't want the nurse, and I don't want your receptionist, and I don't want anybody else other than you to see my data. No, we don't say that. They see it all the time, okay? So why do we allow that? Well, because what we say is that the doctor has an agent. The doctor is allowed to have agents. They can't do all of these things by themselves. But I trust the doctor, and the doctor builds their organization in a way that fulfills that trust. Okay. And now this entire system is built to serve the doctor. So it's not, we didn't say we would sell the data to the pharmaceutical industry or whatever. All of this entire structure is there as what we call the agent of the physician. Okay. And so it's just like a nurse, or just like anything else, anybody else that works with the doctor. They follow the rules that the doctor has set, and the doctor follows the rules that society has set around that.
To me, we need to put far more investment into family doctors and primary health care. That I've been involved, 20 odd years ago, we had a big review in the UK called the Wellness Review, was to try and shift back to primary care. And 20 years later, it's got less. We have,
it's the same. It's the same here in Canada and everywhere. And Chris, I'll explain to you. It's very simple. It's very simple. The reason why we do these things. Okay. Politicians have a lot of pressure. Okay. If you cannot see your doctor in a timely manner, who do you call? You don't call your GP. You call your politician. And they feel the pressure. So what do? They can't double the number of doctors right away. But what they can do is they can expand the access to care in the emergency department. Okay. Yeah, because it's easy. And so, I have a nice little diagram that, I don't have it easily accessible here, but, I just say, look, here's a patient with something simple, not even life-threatening, something simple like a urinary tract infection. Now, urinary tract infection is not something that you can wait for a week to see your GP, okay? So if you call your GP's office, then you say, hey, I've got a urinary tract infection, I need to see the doctor today. And they say, I'm sorry, the doctor is not available, it's not working today and tomorrow, and the earliest appointment I have is on Monday. What are you going to do? You can't say, okay, I'll wait till Monday. You have to get the care right away. And so I think that is a big part of the pressures that we've had to deal with, is that the number of chronic diseases and the number of preventive things that a GP has to do, they're just too busy doing that to look after the acute things that come in the door. And so instead of us being thoughtful about that and saying we need to invest more in primary care to be able to deal with that, we've taken the easy route and just invested in the emergency departments because it's easy to do that.
I don't know much more I can agree with you on that.
Yes, exactly the same in the UK. That's 100% for sure.
Of course. Yes, exactly. Everywhere. It's not just, it's funny, like even Denmark and Norway and all those places are facing the same issue. And, I'll just give you one other example that I share with my students, because I think it's another illustration of why we invest in more in the hospital sector. Okay. So, I said to them, just let's imagine Fred and Joe. Okay. Fred and Joe are truckers. So Fred walks into, the truck stop, and he sees his friend Joe there and says, Joe, it's really good to see you. And Joe says, oh man, Fred, it is so good to see you. I'm like, Fred's like, what are you talking about, Joe? He says, well, I almost died last week. What do you mean you almost died last week? He says, yep, I was driving along and I feel this chest pain. And it was really bad, Fred. It was really bad. It says, I drove myself to the emergency department because that's what truckers would do. They would not call 911. Gets to the emergency department, and they grab him, and what do they say to him? Do they say to him, Joe, you've been a bad boy, you've been eating unhealthy food all these years? No, they don't. They say, oh my God, we're so glad you came. We're going to catch this in time. They do all these tests, they put an IV into him, and 20 minutes later, they have a full workup done, and they say to him, Joe, you're having a ST segment elevation heart attack. Can we give you a clot buster? And Joe says, of course. That's why I'm here. So it says, Fred, you won't believe it. They gave me the shot, and 20 minutes later, I'm as good as new. And that happened on Friday. It's Monday this morning. And, they just kicked me out of the hospital last night. Now, so I say to my students, I said, look, Fred, has just met his friend Joe, who, almost died last week. What is Fred thinking right now? Is he thinking, oh my God, I better start looking after myself? No, why not? He should be, but no, because what he's thinking is that, oh, wow, 3 days? You got a heart attack, you got treated in 3 days, and they kicked you out of there? So I said to them, now, what do you think Joe is having for breakfast this morning? Is he having oatmeal, or is he having 3 eggs with bacon? Okay, right. I mean, I don't think you need and the thing is that the technology is as magical as that these days. Okay, I remember when I went to med school, a gallbladder operation was a 3-week event, right? You came in, and you were, they opened you up, they took out your gallbladder, you were in the hospital for a week. If there was any complications, you were there for another couple of weeks. These days, gallbladder is a day surgery. It's a half a day surgery. They get it done. You're out. You don't even come into the hospital. Okay. So there's a lot of these technologies that have just made life so much easier that, well, it's a no-brainer to invest in them. But over years, when you over-invest in that, well, that gallbladder could have been prevented. The heart attack could have been prevented. That all of these things could have been prevented if we had invested on that side. But we didn't, and we just made it easier and easier for people to get sicker because we've got fantastic treatments for it. And I think that's good from a societal perspective, but it doesn't reduce our obligation to also prevent.
Thank you. Really appreciate that conversation. I can't believe we've come to the end of time, in fact, over time, because I could listen to you for days, I think, talk about and share your experiences. I think I appreciate that we're specifically in the healthcare sector here, which obviously with my background in pharmaceuticals is one I'm very familiar with. But I think that there are so many points that you raised that are relevant to all sectors. So one thing you said was around calculating the value of prevention. It's almost that cost of doing nothing. And I think often when we're trying to innovate or try new things, it's almost that if we could calculate that cost of doing nothing, that cost for the future, all the problems it's going to store up for us, that's a real strong basis, a burning platform almost to then launch your innovation. Something else you said, which I think is always a challenge for us when we're innovating, is how do you track the outcomes? And I think that's what you said was the real benefit of the apps and the AI, and yet something that perhaps is not used as widely as it already should be in many ways. value-based payments, so the payments by results, you know, you're only paying for things when it works. I mean, again, it's a topic that I think has been around for a long time, but again, how often do we embed that in the innovation we do? And then the last thing I really picked up on, which again I think is common to everyone, is that enabling environment. If you don't have that enabling environment, things just wither and don't get started. And I think that's what we, you know, at IDES UK, we try to encourage and support the organisations within our network to have that enabling environment, create that enabling environment ourselves. And I think it's not just about broader how we encourage people to speak up, speak out, share ideas, and then get those ideas implemented and being used. So, as I say, brilliant talk. Love the way you presented. And there are so many, I think, lessons we can all pull out for whichever area we work into. So thank you very much.
Thank you so much for inviting me. It was a really pleasure to have a chat with you guys and have a discussion. Thank you so much.